Good morning, Fresno. Wow, what an awesome turnout. Good morning, everyone. I am so thrilled that you all made time out of your schedules to join us today. Okay, good morning. I'm going to get us started. Good morning. My name is Cara Carter. I am the Senior Vice President for Programs at the California Healthcare Foundation. I could not be more excited when I look around this room. With my colleagues, we were having a conversation this morning about whether or not this was our first official briefing in Fresno. We couldn't come to a conclusion, but I've been at the foundation for 8 years, and it is the first in my time. I could not be more excited to see so many people here. What an incredible room. So before we get started, I want to just acknowledge that in this room, we have an incredible richness of expertise, experience, diversity, folks from all kinds of different industries and all kinds of different backgrounds. And I think that's one of the things that brings us strength as we're trying to transform health and healthcare. I particularly want to note that we are honored to be joined by the Fresno County Board of Supervisor Brian Pacheco, by the Mayor of Madera, Santos Garcia, and by the Mayor of San Joaquin, Julie Hernandez. So thank you for joining us. We are also joined by, as I said, an incredible richness of health plans and hospitals, community groups, clinics, county agencies. We have folks from K through 12 as well as higher education, and we have representatives from offices of other elected officials, both locally and from the state. So an incredible group. I do hope that folks stay and have time to join over lunch and get to know each other and meet each other. So I want to just quickly introduce the California Healthcare Foundation. Many of you know us. I see many old friends in this room and some that might be newer to us. So CHCF is a private independent philanthropy. We are committed to ensuring that all Californians have access to the health care that they deserve and need, and that we can drive towards equal outcomes for health and health care for the state of California. We have our fingers in many pies, but we have 4 priorities that we typically talk about and try to lift up. The first is around making sure everybody gets covered and stays covered regardless of income or immigration status. And I will just name 2024 has been an incredible year for that, with the expansion of Medi-Cal to all adults in California. We do know that coverage is not enough to ensure good care and good outcomes, so there are a number of things that we prioritize to make sure that we get there as well. So once we once people are covered, we have to make sure they have access to the care that they need. And while there are many barriers to that, one of the primary that we see that really drives underneath is making sure that we have a strong, sustainable, vibrant, and diverse healthcare workforce to meet our needs. We also believe that we have to help the system deliver care better to people, particularly those who have the most complicated or complex needs and have traditionally faced barriers to care. So in that vein, we're doing a lot of work to help Medi-Cal deliver the CalAIM initiative to make sure it reaches its full potential to improve care for people with serious mental illness, people experiencing homelessness, and other people with complex health and social care needs. And finally, like many of our partners and like many of you in this room, we're focused on health equity. It is the frame through which we make all other funding decisions and decisions strategically to think about how all people, regardless of zip code, race, gender, or age, receive high-quality care that meets their needs. We're bringing that lens, as I said, to everything that we do, including things that are emerging for us and for the industry, like ensuring that the new AI technologies that are hitting that are a topic of conversation everywhere we go are providing solutions where they're needed the most. Okay, so we're going to talk a little bit about listening and learning and working together. So one of the foundations of our work, and something we try to do throughout our work, is to listen to the people who are impacted by the health system and to help people who are making decisions really understand the needs of the communities that they're serving. So this is the spirit behind the annual survey that we do, the health policy survey that I'll hand to a colleague to talk about in a minute, and also behind events like this. It is particularly important for people who are making decisions about healthcare statewide and in this region to understand and respond to what matters most to the people who live and work here in the Central Valley. My colleague Christoph is going to shortly walk through findings from the latest poll that we did here in the Central Valley. And I just want to name that we hear your concerns loud and clear. So primarily, overwhelmingly, we hear concerns around healthcare costs. More than 6 in 10 people here in the Central Valley say they have skipped or delayed care due to cost in the last year. And as I named the pieces on workforce earlier, that resonates with folks here in the Central Valley as well. Half or more of Central Valley residents think that their community does not have enough providers, particularly mental health providers. That said, one thing that I found heartening is that the things that are of the biggest concern to people here in the Central Valley, the things that you all name as your top priorities, reducing what people pay for care, medical debt, access to mental health care, and ensuring that we have enough providers for mental health and primary care are the same things that are top of mind for us at the Foundation. So finally, I'll just name that the Foundation strongly believes that we can and should have higher expectations for our healthcare system, and that to help the system reach its fullest potential across the state and here in the Central Valley, we need to work together, which is why rooms like this are so important. So I'm so excited to share in this time with all of you here in the room. I know and I see so many local leaders and health leaders coming together to make care more affordable, more accessible, and more people-centered. On behalf of the California Healthcare Foundation, I'll name that we're eager to learn from you all, to continue the conversation about what is needed, and to hear what's working and not working when it comes to making the system work better for all residents here in the Central Valley. In a few minutes, I'm going to introduce Christoph Stremikis, and we have what I think is really an amazing program lined up for the afternoon. I'm super excited to listen to. So Christoph is going to frame the discussion up, as I said earlier, by walking through the key findings from our 2024 Central Valley Health Policy Survey, and then we have 2 panels that I'm really excited about. The first is system perspectives, so we'll hear from health plans, hospitals, and clinics that are dealing with access and affordability. And the second is community perspectives. We'll hear from local organizations who are helping patients overcome barriers. So before we do that, I do have some housekeeping items. So a reminder to folks that this session will be recorded. CHCF will send you an email when the recording is available online. Secondly, we will have time for Q&A at the end of each panel, so I hope to hear many voices in the room and a great diversity of thoughts and questions. Thirdly, as I said earlier, I really hope everybody stays for lunch and networking time after the second panel. And lastly, as I said, we're eager to hear from you. This is one of a series of briefings that we do across the state and in Sacramento. Please do fill out the survey in the end. You can access it via the QR code. Share your thoughts about today's event. We would love to know what works for you and what doesn't work as we continue to improve our own work, which is one small part of the work that we're collectively doing to make care better for people in the Central Valley. So with that, I'm going to hand to my colleague Christoph to get our program started for the day. Thank you.
Good morning, everybody. As Cara mentioned, my name is Christoph Stremikis. I'm the Director of the Market Analysis and Insight Team at the California Healthcare Foundation. It is a real privilege to be here with you again today to share some of the findings from this survey, and more importantly, engage in this discussion with local healthcare leaders and community groups that are on the front lines addressing some of the challenges that we've uncovered in this survey and that you all are dealing with every day. I have just about 10 minutes or so to walk through at a very high level the findings of this survey. I do want to start by acknowledging, while I'm the one that's up here talking, presenting the results of this survey, there is a small army of people that did an awful lot of work over a number of months to turn this into just, I think, a really nice, expansive look at healthcare experiences and preferences among people living in and around Fresno and in the Central Valley. So those folks I won't mention by name. I will point you, though, to our website. I'm not going to have enough time to go through all of the findings. There is a lot of detail, a lot of very interesting comparisons that are available in the full survey report, which is available on our website at chcf.org. So as Cara alluded to, this is one of several listening exercises that we engage in at the Foundation. We really want to make sure we're hearing from folks that are having experiences out in the delivery system, how things are going. We have annually for the last 5 or 6 years done a survey statewide where we're talking to or hearing from a representative sample of folks that are living throughout this state, hearing about their experiences with access, quality, and cost, and their preferences for reform within the system, particularly the reform that they would like to see initiated by leaders at the state level. For the first time this year, and one of the reasons we're in this room this morning, is we did an oversample of folks living in and around Fresno in 5 counties. They're up here on the slide for you: Mariposa, Madera, Fresno, Kings, and Tulare. We did that because we've been here several times over the last couple of years, and I don't have to tell all of you, there have been a lot of very interesting, important developments when it comes to healthcare in this region. I'll name just a few. Cara mentioned Medi-Cal expansion. That is certainly something that is changing in the region or really impacting the region. Redetermination is something of Medi-Cal is something we'll probably hear about on the panels that are to come. I know we'll hear about the Madera Hospital closure, and I know that you all are dealing with the fallout from that. So there's just a lot going on, and we thought in this moment it was particularly important to hear from people about how those and other changes were impacting their experiences around healthcare. So I'm not going to belabor the methodology a little bit too much. I think for our purposes, it's important to know that we heard from around 1,500 people. This was a probabilistic sample, and so no one within those 5 counties was any more or less likely to receive a survey or be invited to share their experiences and preferences. And then we took those results and weighted them so that we have a relatively high degree of confidence that what I'm about to present to you and what is included in the full survey report on our website represents at a high level, at a population health level, views and experiences of the adult population that's living within the region. Now, of course, as a caveat with any survey, all of you probably use data in this room. Any one individual's experience may be vastly different from the population overall, but we have a high degree of confidence, again, that within a couple percentage points, these do reflect the experiences of adults living in and around Fresno. So I have a huge challenge to try to walk through all of this data, and I have another challenge, which is trying to get my slide to advance. There it goes. I will begin with what Cara mentioned, which is the findings around cost really jumped out to all of us, specifically cost-related access challenges. Cara mentioned this, but we found nearly 2/3, or around 63% of adults living in and around Fresno reported skipping or delaying healthcare due to costs in the last year. What are we talking about? We're talking about not going to the doctor because someone is worried about the cost of that visit. We're talking about not following through on a recommendation that a doctor made around a test, a treatment, a follow-up procedure because someone is worried about the cost implications for themselves or their family. We're talking about not filling a prescription or cutting a pill in half, taking less than the recommended dose of medication. Those findings are very, very stark. That's 2 out of 3. That's a lot. It's also a real problem throughout the state. This is not a problem that's unique to the region, but it is particularly pronounced in this region. Another thing that really jumped out to us, and Cara mentioned this as well, is the prevalence of medical debt in the region. Nearly half, or 1 out of 2 adults in the region reported carrying some amount of medical debt in the last year. And when we drill down and ask the actual amount of that debt, sometimes these are really, really troubling amounts of money. And so the figure that's up here on your slide is 1 out of 5 folks, or around 20%, are carrying $5,000 or more in medical debt. And we know from this survey and other studies that carrying medical debt also prevents people from going and getting access to care because they're worried about incurring more debt. So it is really a trouble spot. Again, it is a statewide issue. We see troubling rates in both of these areas in our work throughout the state, but they do they are particularly pronounced in this region. Another key takeaway, and Cara alluded to this, were the findings around access to physical health care. I'll show you some mental health care figures in just a second, but we asked people overall How easy or difficult is it for you and your family to get access to high quality, affordable care in the region? And here we found a little more than a third of adults, or 35% of folks in and around Fresno, reporting that it is difficult for them to do that. We followed up and asked, are things getting any better or any worse when it comes to the access and affordability challenges that you've been facing in recent years? And there we found that around the same proportion, or 35%, said things have actually gotten a little bit worse in recent years. Now, we can draw connections to those access challenges, to some of the workforce challenges that came up elsewhere in the survey, and I'll touch on those in just a minute, and I know our panelists will talk about workforce challenges. The take home for me here is those workforce challenges, no surprise to any of you, are impacting people's experience and their access to care in the region. When it comes to accessing mental health, this was another really headline finding, or thing that jumped out to all of us at the foundation. We asked folks, how easy or difficult is it for you to find a mental health care provider that accepts your insurance? And there, again, we found more than 1 out of 2 folks living in the region are having difficulty finding a mental health care provider that takes their insurance. And then, even if you are able to find a provider, we asked about wait times to get in and see a provider that does accept your insurance. And we found 2 out of 3, or 67% of folks, report waiting an unreasonable amount of time to get access to mental health. This, again, traces to, or is partly explained by some of the workforce challenges, and Cara mentioned this in her opening remarks. These workforce challenges are really impacting people's access to care in the region. Again, no surprise to any of you, and I'm really looking forward to the conversation we'll have with the panel later about what folks are doing to try to address some of these shortages. I really need to fly, so I'll just quickly give you some top-line findings in about 4 other areas, and then I'll turn things over to the first panel. Another area that we asked about in mental health is serious mental health, addiction, and substance use issues. Just in terms of prevalence, about 1 in 4 respondents to the survey reported that they or someone close to them has needed treatment for serious mental illness or a substance use or addiction issue at some point in the past. 2/3 of those people report that improvement is needed in those systems for treating folks with substance use or addiction issues. We asked folks about health insurance changes. I mentioned in my opening, about the Medi-Cal expansion and the redetermination that's going on. There are a host of other changes that many folks go through at any time throughout the year when they're changing their employment circumstances or their economic circumstances change. We found that 1/3 of residents experienced some sort of change in their health insurance coverage in the last year. That is higher than the rest of the state. And those are also having impacts on people's access to care and some of the cost-related access challenges that they do face. Among those that changed their health insurance in the last year, 1/3 said that the cost that they had to go and get care increased because of the change in coverage. There were also other impacts around access to provider networks, as one might expect when one changes health insurance. It's certainly, again, it's something that happens throughout the state, but it is particularly prevalent here in the Central Valley. For the first time this year, this was really exciting. We asked about emerging issues around weather and environmental and climate change impacts on health. We found that nearly 60% of Central Valley residents and more than 2/3 of those with lower incomes were worried about the effect of weather on their or their family members' either physical or mental health. And around 1/3 or 30% reported that at some point in the last year, they or their family member had some sort of impact from extreme heat, from pollution, from wildfire smoke that sent them actually to go and get care. And 1 out of 5 actually went and got some sort of treatment from a mental health care provider that they can trace directly to one of these environmental changes. 3 more things and then I'll finish. One finding is around racial equity, which Cara mentioned is a very big priority at the foundation, and I know is a big priority for many of you here in this room. we found that around half of Central Valley residents and more than half, or around 60% of those with lower incomes, say that the healthcare system, however they define that here in Fresno, is treating people unfairly based on race or ethnicity. Those numbers do rise among folks who identify as Latino or Latinx. Around half, or 49% of Central Valley residents say California overall has made some progress in achieving or improving racial or ethnic equity in the system. And the other side of that, of course, is around half are saying California has not made sufficient progress in recent years. A last sort of substantive area that we'll talk about before we get on to policy and then conclude are views around hospital closures. This is obviously something that's been in the news a lot around here and something I know our panel is going to dive into a little bit. We asked folks about this, and not surprisingly, people in the Central Valley are more worried or more attuned to hospital closures and more likely to have experienced a hospital closure in the last year or two. I think that makes intuitive sense to everybody sitting in this room. I think a really interesting layer or additional set of data that this survey brings to bear on this question is what impact is that having on people? And there we found about a third, or 32%, report driving longer to get care because a hospital closed. Around a quarter, or 24%, report waiting longer to get care. And around 15% report skipping or postponing care because of a hospital closure. I know those are things that are going to come up more in our panel, and it's probably intuitive to all of you in this room, but I'm really looking forward to the discussion about how people are addressing and trying to mitigate those impacts. I'll conclude then with just a minute about priorities for reform. When we ask people what would they like to see their policymakers in Sacramento do, we ask an overall question. How would you prioritize healthcare within all the range of things that folks in Sacramento are tasked with trying to address, be it climate change, the cost of goods, general inflation, improving public education, doing other public health investments. And here I'll tell you that healthcare always rises to the top, or is among the top, one of the top priorities for folks across the state, and it's no different here in the Central Valley. 9 in 10 folks here in the Central Valley want policymakers in Sacramento to prioritize healthcare. I think it's very important for them to address healthcare in the coming year. And then the slide I'll conclude on are specific priorities within the healthcare system. What do folks want their policymakers in Sacramento to focus on specifically to improve the healthcare system? And Cara touched on a couple of these, but the things that really jumped out to us were, number one, they want policymakers to do something about the cost of care. That makes intuitive sense because so many folks are experiencing cost-related access problems. Number two, folks want policymakers to do something about access to mental health care. That, of course, makes sense, if, tying it back to some of the earlier findings around those access challenges, finding a provider that takes your insurance, the wait times that people are experiencing getting in to see a mental health provider. And then number three, folks really want state policymakers to prioritize the workforce, to make investments that will increase the number of providers that are available to hopefully address some of these access costs and quality challenges. So as I mentioned, there is a whole bunch more information and data that's available in the full report that's on our website. I would encourage you to go and look through that and dig into it a little bit. If you're interested in any of the number of findings that I presented here today, I could not do justice at all to any of it. That's available on our website at chcf.org. And if you have any questions or would like to dig into the data with any of us, please let us know. So with that, I'm really excited to bring up our first panel to talk a little bit about frontline experiences, both challenges, opportunities, successes that folks have experienced addressing these and other issues in recent years. And so I'll invite them up to the stage and invite or introduce my colleague Diana while everyone is getting situated. Diana is my colleague. She is a senior program officer on CHCF's Improving Access team, which works to improve access to coverage and care for Californians with low incomes. Diana also leads our emerging work on Latino and Latinx health equity. Diana has a really impressive background, previously working at Kaiser Permanente, John Muir Health, and doing some work as a social worker and public health educator around folks living with HIV and AIDS. Her full bio is in your packet. I would encourage you to go take a look. And with that, I'll turn things over to Diana to introduce the rest of the panel and enjoy the conversation she's about to facilitate.
Thanks, Christoph. I didn't know I'd get an intro. That felt fancy. Hey, everyone. Good afternoon. Welcome to our first panel. I'm delighted to be kicking off and moderating this panel of esteemed healthcare leaders in the region talking about access and affordability and a lot of the topics that came up in the survey. So I'd like to welcome our panelists to the stage and do a quick introduction of each of them. So first we have Dr. Joel Ramirez. Joel is the Chief Medical Officer at Camarena Health. Camarena Health serves over 70,000 people across 2 counties in Madera and Fresno. He's a physician by training, if you didn't pick that up from the doctor piece, and he also has an MBA. I'd also like to welcome Jeffrey Nkasa. He is the CEO of Calviva Health, a local health plan serving Fresno, Kings, and Madera counties. He has a background in health education and public health. And last but not least, I'd like to welcome Ryan Gates. He is the Chief Population Health Officer. He's also a pharmacist, and he comes to us from Cahuilla Health, a health system serving Tulare and Kings County. So welcome, panelists. Excited for our conversation today. To kick us off, I really want to start with some high-level questions around the health ecosystem related to health care access and affordability in the region. So I'd like each of you to talk about a specific problem or challenge you see playing out in your communities amongst your patients. I'd love to hear if it's related to some of the survey findings or if it's actually something that surprised you didn't show up in the survey. So with that, maybe I'll start with Ryan.
Sure. I think from a high level, one of the challenges that faces our community, and from a hospital-based system, we're the largest healthcare district in California. We have 5 rural health clinics and commercial practices and urgent cares. We also have a hospital, the only acute mental health hospital in the county, and so we see different aspects of patients' needs from just them reaching out and accessing the different points of care for our health system. So I think I have a different lens in terms of what I see as need in the community, but largely, I think we are getting better at access, but access to quality care is a gap. And I think amongst the managed Medi-Cal population in particular, one of the challenges that exacerbates that is, and this is a statistic in the article or in the survey, that a bigger percentage of Central Valley residents don't have a relationship with their primary care provider. So in the Medi-Cal space, in the commercial managed space, when you get a commercial health plan, you choose your primary care provider by name. And in Medi-Cal, you get assigned typically a clinic as your primary care home, but you don't necessarily see the same provider every time. And so when we're discharging patients, trying to get DME order signed, or who do we discharge this patient to, there's a big challenge around the access to quality and continuity of care, and that provider-patient relationship being held in high view and facilitated. So I think that's one challenge I see personally.
Yeah. Dr. Ramirez, anything you'd add as a primary care provider yourself?
Yeah, I think for me, it kind of touches back to what Christoph was sharing earlier, and it's access to mental health and substance use disorder treatment. Within our organization, we employ behavioral health clinicians that are capable of managing mild to moderate conditions, but for those severe mental illness, substance use, addiction issues, we look to refer those out to external resources, and finding treatment centers that are able to manage these conditions is sometimes a challenge. Finding these treatment centers that are able to accept all the varying insurance types for our patients is also a challenge, including for those low-income patients that may have little to no insurance. And then finding these treatment centers that are able to offer this treatment in a timely fashion. We heard Christoph, touch on that as well. And lastly, being able to have these treatment centers deliver that care in a language that our patients understand. So I think these are all challenges that we encounter as a community clinic. And I wasn't surprised to see the data actually in the CHCF report. I think one of the slides there showed that 56% of respondents felt that there are not enough mental health providers in our community. Nearly 50% felt that there's significant improvement needed when it comes to severe mental illness. And that number jumps to 70% when you lump in those responses that included some improvement is needed. So, I think part of the problem, though, is, aside from reimbursement rates, is just having the necessary infrastructure to be able to manage these conditions. That often calls for case managers to be on staff, for specialized training of behavioral health clinicians as substance abuse counselors, for on-call medical providers, and for medical providers to receive additional training as it relates to the prescribing and monitoring of medications. So I think those are all hurdles we're going to have to overcome.
Jeffrey, anything you'd add about biggest challenges you're facing in some of your work?
Yes. So, one of the things I want to start with is I've been in Fresno here since 2009, and I've been able to see how we've been able to progress over the years. And in my role here at CalViva Health and being able to lead the largest local Medi-Cal plan here in the Central Valley, one of the things I've seen around timely access to care is around specialty care. And specialty care has been a challenge that we've continued to see, whether that's access to gastroenterologists, psychiatric care, orthopedic surgery, and rheumatologists, and just to name a few. But even though we've had those challenges, we've continued to be able to solve for those in several ways. For example, earlier it was primary care physicians, and we've been able to solve for those challenges in some cases by being strategic, by trying to build the workforce there and recruit more physicians to the area. With regards to specialty care, we've kind of looked at strategies such as electronic consultations. We've worked hard over the past couple of years in the Central Valley, standing up a Central Valley collaborative focused on electronic consultations, which will allow possibly the opportunity for some care to be managed at a primary care setting. The hope of that is that if it's being managed at a primary care setting, it would allow opportunity for a visit to occur, and then for an electronic consultation to occur with a specialist provider, and then hopefully for that information to get back to our primary care so that that information can get back to the patient. And that would allow for it to be managed and also allow for additional availability in the specialty care arena. So that's kind of an additional strategy there. In terms of the survey data, we are looking at timely access to behavioral health, and that is an area as well that we're starting to focus on again, strategies and unique ways to solve for that as well.
Great, thank you, Jeffrey. I think we heard, primary care, mental health, behavioral health, as well as specialty care. I swear we didn't plan that, but the spectrum of healthcare access needs in many communities being particularly needed here in the Central Valley. So I spent a lot of time thinking about how to increase access to care and affordability for low-income Californians and people of color, particularly those on Medi-Cal. One of the things that struck me from the survey was the number of inequities we saw in the data, whether it be by race or ethnicity or income level. In particular, for example, Latinos in particular have a harder time accessing primary care or physical or substance abuse disorder care than their counterparts. So I'm interested to hear from you about what health equity issues you see as important to address and any examples on how your organization has successfully tackled some of these inequities in access to care. So maybe I'll start with Dr. Ramirez.
Yeah. So I think given our rural geography, where access to resources can be limited, we tend to see a number of different health equity issues come up that can include differences in burden of disease, as well as lack of access to general medical care, but as we've already touched on, mental health care, underinsured or uninsured situations that can complicate care. Within our organization, we have a patient population that identifies 67% Latino. And we see higher rates of diabetes and obesity than in other parts of the country. And I think in large part that can be contributed to by system inequities that create hurdles to healthy, nutritious foods, access to safe parks and playgrounds, educational programs. Low literacy or educational achievement can influence the ability for our patients to understand specific instructions around the use of medications or the rationale or importance of medical testing. Our patients struggle with these things I think at disparate levels. I can recall graduating from training in Los Angeles and moving here to provide care and taking care of a patient whom I just diagnosed diabetes in, and after going through the mechanics, I was going to use insulin, and after going through the mechanics of how to attach the needle to the syringe and drop the insulin and how to select where you're going to inject, I reminded him about needing to refrigerate the insulin, and he asked, well, how can I do this if I work out in the fields all day? And it gave me pause, and I had to actually think about that, and I realized that I was going to need to become better informed and more creative about how I was going to care for my patients here because of that. But I also thought about how many patients I had already prescribed insulin to who maybe had not felt comfortable enough to ask that question and who had gone on managing their lives and trying to figure out how to do this. Apart from the things I've just talked about, our patients struggle with things like transportation, things that maybe not be top of mind for you and I in this room, but it's not uncommon for me to see our patients walking to our clinics. They have to coordinate a means to be able to get to their appointments. Apart from coordinating childcare or time off from work, it's asking a friend or a relative for a ride to their appointment, or taking buses, or as I shared, simply walking to their appointment. So, unlike for most of us, if we get a phone call for an earlier appointment that's available later today, we can hop in our cars and get to that appointment with no problem. But this is not always the case for our patient population. Some of the things that we've done to help address some of the health equity issues I've described is we have a clinical pharmacist on staff. Although this is not a billable service for us, we see a huge value in having a pharmacist to collaborate with. And this pharmacist performs visits for our patients just like medical appointments. They're able to sit down with patients and spend time reviewing medications, reviewing the why, the how, the when for each of their medications, which really helps to encourage compliance and understanding, and hopefully is helping to contribute to better outcomes for patients. And he does things like he draws a sun on pill bottles for medications that they need to take in the morning, or moons on pill bottles that they're supposed to take in the evening. So again, it's been really a really great addition to have a clinical pharmacist on staff to help with those types of health equity issues. We've done other things such as having insurance enrollment specialists that can help guide patients who may not have insurance on what programs are available for them to access the ability to have mammograms performed, cervical cancer screenings, or for children to be able to have their annual physicals performed and get their vaccines on time. So these are just some examples of ways that we've tried to address some of those health equity issues.
Yeah, that's great. All the social determinants of health, as well as the things you can do in the clinic. Thank you, Dr. Ramirez. Jeffrey, anything you'd say about how to address inequities from the health plan level?
Yeah, one of the key things from a health plan level, and one of the key health equity initiatives that we're focusing on is health literacy. And health literacy, to me as a leader, plays a particular role to me as well, because it doesn't matter what your income level is, what your background level is, where you're working at, it's going to impact you in one way or another. And I actually had the unfortunate situation as well where we had a family matter that we had to take care of, and we needed help. And we had a family member come to us and give us some assistance. They were from a socioeconomic background, but they came from Georgia here to stay with us in California, here in Fresno. And it was a circumstance where we were wondering, well, how long were they going to be with us? Is it going to be for a couple months, or is it going to be for a year? And they had health care under the Affordable Care Act. But as they were here, we knew that, well, you should make sure that you have insurance. But they felt that their coverage would allow them to still be able to get care. And as they were progressing, again, that's a factor there in terms of they were underinsured, because as things started to happen, they didn't actually have access to get care here in the location where they were at, and that became difficult, but they just didn't understand that or have that information. And even though we were able to, advocate for them and tell them that you should try and make a change, we were not that we were not that trusted messenger at that time to really be able to spark that change. So they continued on with the care that they had. Then, as it progressed, they actually started needing more care in the sense, in terms of things were starting to happen. But they weren't being able to be clear in telling us what was going on. They weren't. They were self-medicating, and they were afraid to go see a doctor or afraid to go to the hospital. And that's a lot of times stories that I continue to hear. And again, it's that component of, do you have the information? Are you able to go get that information to try and see if you can advocate for your own care and needs? And as it continued to progress, unfortunately, we reached a very point where, they landed at the hospital. And they presented at a hospital as a minority, an African American with no health insurance, not having the additional understanding of how the healthcare system worked, and being very basically just not having, even though we were there, it was difficult for us to advocate for them because it was too late at that particular moment in time to put all the steps in place that would be needed to have a successful outcome. And I stand here in front of you as a leader, still impacted as a health literacy nature, because in February of 2024, we lost that individual. So again, that's one thing as a health organization, as a leader, that I want to make sure that our organization continues to strive, and we are making efforts in those areas as well. We at Calviva Health recently had a breast cancer screening awareness project that we won a quality award of, which was a health equity initiative. And one of the things that we did was we reached out to the population, which is serving the Hmong population. We reached out to understand, what the barriers were, what the health equity and what the health inequities were, so that we can try and solve and cure for those. And we learned things like maybe transportation could be a help. There was a fear to getting those services done. So it all starts, with basically trying to educate. Trying to educate and trying to meet people where they are and understand those needs that you have to try and solve.
Great. Thank you for sharing that story. I'm sorry. Ryan, anything you'd add about efforts around health equity?
I fully concur and won't reiterate prior points, but one area of inequity that we are really focusing on at Kauai Health is maternal equity. And so particularly amongst our farm worker population. So those of you who may be familiar with the CalAIM program, on January 1st, birth equity became a population of focus where patients are eligible to receive enhanced care management services. However, Latino population was not included in that. And we feel, and partnering with UC Merced and UC Berkeley Farm Worker Study, the inequities are well documented and substantiated. And so we've been awarded 2 very large long-term 5- and 4-year grants to invest in addressing health inequities amongst the farm worker population, and very excited about that, and our partnerships with Lindsay Unified School District and the Family Resource Center and Tulare County WIC office, Altura Health, and our collaboration is growing, and we're getting momentum behind that. And we have a meeting with Dr. Paula Babaria from DHCS to talk about how can we advocate to the state to add farm workers as a population of focus for birth equity so they can get enhanced care management. So excited about that.
Thank you. That's a great example. I'd like to move the discussion to talking about some of the local and regional issues that came up in some of the survey findings that have really created significant access challenges. First, a common topic at the regional and state level, frankly, the closure of Madera Hospital. So can you talk about the impact that has had on your community and how you've adjusted as an organization? And maybe I'll start again with Dr. Ramirez, since that's right at home in Madera.
Yeah, so, I serve as the Chief Medical Officer of Camarena Health. We are a federally qualified health center, primarily located within Madera County, although we do have one clinic location in Fresno. So certainly this really hit home for us in the city of Madera, and I'm sure that for those here, you've heard countless reports and stories surrounding the closure of the hospital. And I think apart from the sheer shock of just the hospital closing, I think the abruptness was something that we struggled with. At the time, we were given maybe about 2 weeks notification that the hospital was going to be closing, and so we had to quickly pull our team together and try to determine what we might be able to do to ease some of the losses that were going to ensue. Perhaps given some more time, we may have been able to come up with a more formidable response, but we had to act quickly. And so some of the early steps that we took to help address this was expanding our urgent care hours of operation. We added additional urgent care providers, recognizing that there was going to be a loss of urgent care and ER services in the community. We also expanded our primary care locations and added primary care providers. In fact, we onboarded a couple of providers that were previously employed by the hospital to work in their outpatient clinics because this was intended to help care for those patients that were going to be displaced from the outpatient clinics the hospital operated. And then we went through a number of some programmatic additions as well, and one of them had to do with specialty care. The hospital operated a outpatient specialty clinic that covered a number of specialties that included general surgery and nephrology, cardiology, pulmonology, infectious diseases. And with the closure of the hospital, that also meant that this specialty clinic was going to have to close, which was devastating for patients who sought their care regularly from these specialists and had established relationships with these specialists. So we went through the process of petitioning our federal oversight body, which is HRSA, to bring these specialty services within our scope of care. It's generally an application process that takes a few months to be approved, but just given the extreme circumstances that we were in, we were fortunate in that that approval process was accomplished within a few weeks' time. Then came the step of reaching out to all of the specialists and asking if they had any desire to want to now partner with us to continue to provide care to the patients. And I'm really proud to say that every single one of those specialists said, absolutely, when can I start? And so we were able to, in short time, bring all of those same specialists on board in a specialty clinic to continue to offer those same types of visits to their patients, which has been a really great thing for the community. We also were able to add a gestational diabetes program. In the past, we would refer expectant mothers who had diabetes over to the hospital for their Sweet Success program. And this was a program that helped them to just navigate having diabetes while being pregnant, which is certainly a challenge. But again, with the closure of the hospital, that was something that we had to try to internalize, and thankfully we were able to do so, so that now we have a program within our organization that is able to keep all of these patients in-house and continue to manage their diabetes throughout pregnancy. Similar to that program, we also incorporated non-stress testing for pregnant women who need to have some cardiac monitoring for themselves and their baby. So just a couple of programs that we're able to internalize that didn't require for us to refer these women out to Fresno or to Merced to have these types of tests performed. Still, there are gaps that remain. I think that we are in desperate need of an emergency room within the community. Despite our best efforts to increase access to urgent care, there are some conditions that just cannot be managed in the urgent care setting. And at the very least, when a hospital reopens, we would hope that an ER would be a part of that reopening process. And we also would hope that the OB program that was previously in place would also be something that would be incorporated into a hospital reopening. We manage thousands of lives each year of women who are pregnant, and these would all deliver at the hospital, and now they're having to drive to Fresno, drive to Merced to deliver, which means they can't deliver close to home. That's also a challenge for issues that might arise during pregnancy, sometimes urgent in nature, in which they can't just go locally to their hospital, but have to, again, commute 30 minutes to the nearest hospital. It's also resulted, and I'm sure we'll probably hear about this maybe from Kauai, but in the overcrowding of emergency rooms, as they've had to now adjust to the increased volumes of patients that are now showing up for care.
Yeah, and to that end, Ryan, anything you'd add? I know you're not in Madera, but as you think about hospital sustainability from Kauai's perspective,
No, nothing to add. We have about 5 or 6 hospitals between us and Madera County, and so directly, we're not seeing Madera patients bypassing all of those coming to our ED, but secondarily, we transfer back and forth a lot between our community hospitals in Fresno and Kauai for various things. And we know that Fresno is deeply impacted by the closure of the Madera Hospital. I think, the bigger point here is that, Madera is kind of like the canary in the cage. The coal miners put the canaries down there, and they died first because they were small little critters and they couldn't handle the poisonous air. The hospital systems in California, in particular. I mean, I don't know if you were born at Lindsay Hospital. I know Sonia was.
Exeter.
Oh, well, there you go. 2 hospitals, Lindsay and Exeter and Dianeba, are hospitals that are all closed today. So it didn't happen in the last 12 months, but it's happened, and it's an increasing risk to the hospitals in California. So yeah, it's certainly was a wake-up call, I think, for a lot of folks.
Jeffrey, anything you'd add about this topic?
The only thing that I would just add is just from a health plan level. I know that with the closure of the hospital, it's caused a lot of impact on the area hospitals. So the health plans collaboratively have been working together to assist in transitions of care, kind of evaluate how the network are, and look for alternative places to discharge patients when they're in the hospital. So we are looking at innovative ways. We're looking at ways in how we can leverage our network, things like recuperative care possibly as an area in which maybe that can help expand an additional opportunity with the hospital closure. And then one area as well that we continue to have conversations about, but I know those conversations are more long-term, and that's around long-term acute care hospital in the area. But that's the only thing I would just add from that perspective.
Thank you. Another issue that Christoph and Kara both mentioned in the opening was just all the changes in Medi-Cal right now. In particular, kind of 2 big items. First is the broad and historic expansion of Medi-Cal to all low-income Californians, regardless of immigration status. And the second big thing happening in Medi-Cal is, for the first time since the pandemic started, Medi-Cal is redetermining eligibility for its membership. So this is a big topic at the state level right now, and I'm interested about how that's hitting home for you all here in the Central Valley. What challenges are you seeing? What strategies are you deploying to kind of address these 2 big changes in the Medi-Cal delivery system in California? So maybe I'll start down the line, back over at you.
Sure. Honestly, praise God, right? I mean, I practiced for 10 years at Curran Medical Center as a clinical pharmacist in diabetes and hypertension and other chronic conditions, and before the ACA, and I would have, parents bringing in, or, children bringing in undocumented parents and trying to get them access through 340B program and getting them insulin at 10 cents a vial because I can buy it through 340B, and all these workarounds just trying to serve, right? And so if that would have been in place back then, it would have been a different story. So thankful for that, right? Thankful for that expansion. However, there is a lot of still hesitancy, right? If you're undocumented to seek care and to trust that, okay, if I sign this paperwork, La Migra's not going to come to my house, right? And so we've benefited from a long legacy that precedes my time at COIA through a very, very healthy and robust community health, a community outreach division at COIA. So employing promotoras, community health workers, participating in the DHCS navigation program, where we're out in the communities, home visits, out in the fields, holding events, hiring people from the rural communities to be that promotora. And so now they're hearing it from, a neighbor or somebody that they can know and trust, and getting them to trust to enroll. And now we can get them access, and get them enroll in the program. So we've got my team over here. I mean, they just do amazing work in that area. So I'll cut that short at that. But.
Great. Dr. Ramirez, I know most of your patients have Medi-Cal or will soon have Medi-Cal.
Yeah, no, it's definitely a program in flux right now, I think is a great way to put it. On the one hand, we have an expansion of benefits, which is fantastic. It's going to allow for additional patients to now have access to preventative screenings, regular health care, dental services, which will hopefully translate into better quality of life and longevity in the long run. But on the other, we're going through a redetermination process, which was put on hold during the pandemic, which granted patients the ability to just have ongoing participation. But, as Ryan was sharing, there's hesitancy when it comes to filling out these forms, and it has questions about your legal status. And we recognize that. So some of the things that similarly what we're doing is we're sending out messaging via our portal system. We have posters throughout our clinic locations. We have staff identified throughout our facilities to help provide education and assistance with filling out of these forms. And we also have a promotoras program as well that goes out in the community and helps to calm the fears and answer any questions. But yeah, we're hopeful. I'll admit that to date, we have seen lower numbers of participation, and we're hoping that with an extension, there's going to be additional individuals signing up.
And what does that mean for your health system? If people don't sign up for Camarena Health, what are the implications of that?
Yeah, well, I think it goes back to some of the things that we've been talking about before, in that it impacts care. And some of the things that we're talking about early as far as health inequities, these delays in care have real life complications for patients to delay their care, allowing those conditions to progress to levels of severity that require higher levels of treatment, more costly procedures, medications. And so, those are all things that we're trying to avoid by granting greater access to care and participation in programs.
It really hits home. And from the health plan perspective, this is all about your membership. So in terms of redetermination and expansion. So what have you been thinking about? What are the impacts, and what are some strategies you're all deploying?
We've been doing a lot of the similar strategies that Ryan and Dr. Ramirez already mentioned, making sure that we've been partnering with the community-based partners, the trusted messengers, putting out the materials, the flyers. From a health plan level as well, we've also been doing a lot of outreach calls, text messaging campaigns. We try and connect through those avenues as well, just trying to make sure that we're conveying the same message to stay insured, keep your care, so that you'll be able to access your healthcare benefits when needed. So we're doing a lot of those strategies as well. Also, you mentioned about the changes in Medi-Cal and a lot of the new programs that are taking place. So we've been doing a lot of education in that sense as well, letting them know about the new CalLane benefits that are in place. And that education has been a little bit strategic in terms of how we take place there. So in that particular example, we've been working very closely with our provider partners. And then there's a lot of community-based organizations who ordinarily, historically, we didn't usually interact with in the Medi-Cal space in terms of Medi-Cal billing and those kind of community support, CalLane benefits such as community supports and enhanced care management. So we've been doing a lot of education and training and awareness to those organizations who are serving in that space as well. So that's kind of a lot of the strategies that we're...
And as we do, I heard a lot about education and training and outreach. What do you all see as the barriers, to that? We can do that a lot. And what are some of the real barriers you're seeing day to day or noticing in some of this work?
For me and what I've been able to see, it's just so much information. There's so much data, there's so much complexities, technicalities about the various new programs, benefits, who's eligible, who's not eligible, what population of focus. There's just so much. So, we've been trying to take it little by little, but I guess the best way to put it is we've been strategic in how we message the community to try and make sure that it's not so overwhelming, that we provide a little bit of information so that the uptake is taken, and then at that point in time, then we will add more as that time comes.
Yeah, I think having my prior life been a high school educator and coach, and then in patient care, directly working with patients. And training our staff, on techniques, motivational interviewing. It really gets down to the fact that we can have a great campaign, but if that frontline person interacting with that other human being across from them doesn't have the training and technique to understand how to connect with this person on a real personal level and build some trust, I don't care how pretty your posters are and all of that, right? And so Again, our team, Sonia Duran Aguilar and the team, they just do a wonderful job of really onboarding and training our community health workers and promotoras in how to make that connection to then affect change, you know.
Well, we're going to go a little bit high level back again, zooming out for some local health issues, thinking about the broader context. Looking forward, put on your 2 to 3 year cap. What are the top 2 to 3 regional health challenges your organization is prioritizing in the coming few years? Specifically, I'd love you to talk about what are you planning to do? We talked about trust, who are you planning to partner with? And also, what do you need to be effective at? Not just as a health system, but from your community, from the ecosystem of healthcare. What do you need to be successful in these challenges that you're tackling? So maybe I'll go down the line if you want to start.
Well, I think one area that we're placing a high emphasis on for next year is staffing, workforce development, basically. We've struggled with some staffing issues even prior to the pandemic. And so in trying to be creative about our recruitment and retention efforts, we're going to be preparing a couple of programs that is going to be intended to home grow some of our staff. One of them is a medical assistant training program in which existing staff will have the opportunity to be trained as a medical assistant. Perhaps they're high school graduates working in a clerical position and have a desire to want to get into healthcare, and this will allow for them to do that. So we're working and exploring this with Central Valley Health Network, a local organization, as well as some training partners to develop the curricula that we'll use to certify these individuals as medical assistants. The other area of emphasis is really looking at our aging population. And so, it's projected that, within the country, those individuals age 65 and above by 2050 are going to increase up to 47%. That's a huge increase. Our U.S. population is more seasoned and experienced than it's ever been. And so in trying to prepare for that, we are going to be working to develop a senior health center in Madera that is going to be wholly dedicated to the care of adults age 55 and above. We're taking great care in the design of the facility, in the staffing that we'll be selecting to work within this location that will include medical, behavioral health, and health education. We've already got a pediatric dedicated facility, but we want to do something on the opposite side of the spectrum, and we're really excited about what it's going to look like and where that will lead us.
So workforce, aging, what are the big looming challenges that you foresee, and what help do you need to make it happen, Jeffrey?
So we're focusing a lot on workforce as well, but primarily we're doing a lot in the nursing space. So we've partnered with a organization in the 93706 zip code, Image Church, which is aimed at trying to develop the next level of certified nursing assistants. We're doing some hope there that some investments there, so hopefully the pipeline from certified nursing assistant to LVN to RN will hopefully create a pipeline of nurses that would help that community background, that community in that area. The other thing that we're focusing on is we're doing a lot of partnership as well with the community health systems and nursing there as well. They have a program where they're trying to invest in nurses that are already working with them to hopefully shore up their workforce as well. So we've been doing some investments there because we've learned that it helps and it benefits the community when you're investing in your own, because those individuals usually also stay in there and they're also most likely to serve the patients that they're already caring for. So that's what the areas that we're focusing on there. From another perspective, we're doing a lot of investments around the new CalNAME and especially around community health workers. We've been working very closely with the Fresno Community Health Improvement Partnership and their Fresno Hope Pathways. There's a big hub that's taken place, all focused on growing a network of community health workers, which will serve the community and be able to do some care navigation and be able to really lead in that space. So that's the second area that we're kind of taking a look at in terms of investments. The third area is children's health. We're working very closely. We do believe in the cradle to career, the continuum of birth birth until adult, so the K through 12 spectrum. So we're doing a lot of investments there to just make sure that we're connecting organizations, connecting networks, and kind of leading in that space as well.
All right, top 2 to 3. Senate Bill 525, big, I think, issue facing all of us. Wonderful to really strive after a livable wage for folks. However, you know, to be able to, for Kauai, it's about $39 million increased labor costs, expenses to do that for our organization. And when our margins, you know, are, you know, a couple million a year, you have to really, how are you going to accomplish that and maintain services for the community? So that's a big challenge for us. That's a big workforce challenge for us. And we're obviously turning over every stone to make that work. But at the same time, you know, you have the state new Office of Healthcare Affordability saying they're going to cap healthcare expenditures at 3% a year. And Dr. Gowie's plan was, you know, the healthcare leaders will figure it out, and when they do, California will be better off. So we're still trying to struggle how we're going to make both of those, you know, come to fruition really well. On workforce, however, on a positive note, you know, Kauai Health has started its own university, powered by Unitech University, with accredited nursing school, and so we're able to put our employees, you have to be an employee of Kauai Health, and you work part-time, and we put you in through your nursing program, and we foot the majority of the bill. We've had a lot of local kids wanting to get in nursing school, but all of us nursing schools around us are state programs, and they are not able to give preferential enrollment to locals. And so our, like COS, our community college programs in Fresno State, they're heavily impacted by people coming in from San Francisco and LA. They come here, get their education, they work for a year, and then they leave. And then we have all these kids here locally. I want to be a nurse, but I can't move. You know, I'm married, or I can't afford to live in LA. And I apply every year to get into COS, and I just can't get in because I don't get any preference. So we just said, you know, we still work with COS. They're great partners, and it's not their fault. But so we just went the private route. And now we're able to offer BSN training to our staff. Whether you work in laundry, doesn't matter. I mean, it doesn't matter where you work at Kauai Health, as long as you're employed, you maintain your full-time benefits, you accrue your retirement, you get to provide for your family. And we're a GME program. We have 130 physician residents and all the classrooms needed at nights and weekends that aren't used, and sim labs. And so we're really excited about what we're doing in the workforce locally for Tulare.
Sounds like some hope maybe on the workforce front, lots of innovation happening. And I wanted to ask our last question really around kind of a hopeful and positive note. We're talking a lot about challenges and problems, and it's clear there's so many amazing partnerships and robust assets in this region and in these communities to build off on. So I really want to ask my last question with a hopeful tone. Please tell me what excites you about healthcare. Y'all spend a lot, I'm sure more than 40 hours a week thinking and doing this. So tell me, what gets you out of bed to do this work? What are you excited about related to healthcare and the future and the communities you serve? So I'm going to pick on someone randomly. Jeffrey, how about you start?
For me, it is the fact that people slowly by surely are starting to understand and appreciate how important it is to have a health plan or a health insurance. It's the understanding that they understand that now more than ever, it's important to be able to have access to care, access to a primary care physician, a medical home, access to be able to get services when you need it.
Yeah, we were just kind of sharing a little bit about our career paths in healthcare, and you know, we just want to help people. I work in healthcare. I happen to be a pharmacist, right? And so it's my passion to help people. I don't matter, you know, what I do in it, honestly, as long as I work with a great team and we're making a difference for the community. One practical area of partnership, again, I talked about our maternal health and the partners there, but I spent an hour yesterday with the local rural school district on behavioral health. So Kauai Health, we have our own psychiatry residency program. We have the only child and adolescent fellowship program for psychiatry and a very robust therapy. And so being able to get those access points into the rural school districts and working with other people on the other side and other entities that are just as passionate as we are. We have the same patients we're trying to serve, and how can we work together to bring about solutions? So just there's so many exciting conversations going on in partnerships. Sorry about the feedback. that's going on in healthcare, and so we're going to do great things. I'm very hopeful. I love what I do, and you know, with CalAIM, we've got some great tools in the tool belt to really make a difference that we weren't able to do just a few years ago. So.
Well, as a technology nerd, on a personal level, I'll say I'm pretty excited about AI and its possibilities within healthcare. We're already seeing some of AI built into some of the electronic health records systems that are out there. We recently introduced AI to assist us with documentation of patient visits so that providers can spend more time face-to-face with the patient instead of in front of a computer having to type out their notes. So I'm excited about that and the possibilities with AI. But on a larger community kind of scale, I'm really excited about this trend in healthcare towards value-based care and this move away from transactional fee-for-service model towards really putting an emphasis in rewarding the efficient use of healthcare dollars and focusing on quality performance. You know, I'm excited for a couple reasons. I think from a clinical perspective and a patient perspective, it just makes sense to focus on providing good care, good quality care, not just addressing the issue at hand, but really thinking about the whole body person when you're caring for your patients. But I'm also excited for the medical provider perspective as well, because generally, historically, providers have sought to increase the number of patients they see in a day to optimize their revenue generation. In a value-based care world, now the emphasis is switched, and so that they're focused more on doing a good job of taking care of a patient's diabetes than just diagnosing the diabetes. And so I'm just really excited about this move towards value-based care. There's a lot of work being done around it, and I think it's something long overdue, and it's a move in the right direction.
Great, thank you all. So now we're gonna move to some questions from the audience. So there's some CHCF staff around that have microphones. They will hold them for you. Please introduce yourself and bring on the questions. I see a hand maybe in the middle of the room. Is that Hugo?
Oh, okay. My name is Hugo Morales, and I wanted to ask the question to Dr. Joel Ramirez. Your county, Madera, has the highest, it's really hard for me to. Your county has the highest concentration per capita of indigenous people, including a high number of indigenous language speakers, including Mixtecos, Entriquis, Zapotecos, and high level of literacy. Almost everybody's in Medi-Cal. So how have you been, how do you cater to that for the care of these patients within your own system? And then as you're planning your senior facilities, how does this population impacting in the planning of serving this aging farm worker force, which includes indigenas in the language? And have you thought of using trilingual indigenous youth as part of that servicing of this population? Thank you. My name is Hugo Morales. I'm the founder and co-director of Radio Bilingüe.
Mr. Morales, thank you so much for your question. It's an area that I think a lot of us struggle with to try to provide the services that we do in languages that our patients can understand outside of the more generally known language of Spanish, right? There are so many different dialects within Mexico itself, not to just, and that's just counting Mexico, not including other areas of Latin America. You know, it's interesting that you asked this question because I actually came across a very, what I thought was exciting and interesting situation a couple of months ago. We are a teaching facility, and we work with physician assistant training programs, nurse practitioner training programs, as well as medical residency programs in Fresno and the recently opened medical school in Clovis. We had a medical student who was working with one of our physician doctoras, and she was sharing with her that her parents spoke a very specific indigenous dialect from Mexico, and that the traditional words we use to speak in Spanish were not words that her parents would understand. We could not just say, me duele el estómago. You would not be able to just translate that for this patient. And you know, she thought it was so interesting that 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 we would just naturally assume that anybody from Mexico is going to understand Spanish, but that's not the case, And so what this medical student is now doing, and we're hopefully going to be able to do this at scale, is she's putting together key phrases and key words from her specific dialect that we're going to put into pictures that our medical staff are going to be able to use in communicating with patients. And as I said, hopefully we'll be able to do this with other dialects and other languages. And something that we hope to be able to incorporate to our other facilities, as you mentioned, our senior health facility as well. Apart from that, we do partner with some translation services that do offer some languages, but not all, as I'm sure you're familiar with. But I just thought that was a really interesting story and a good representation of the diversity of patients that we take care of in our community.
Thank you, Dr. Ramirez. Any other questions? I see a hand over in the corner by the camera. Oh, she's got the mic first, okay.
Gloria Hernandez, retired Meticha. I'm concerned about the increase in Parkinson's. A long time ago, I read a Sierra Club article in one of the places I was at, waiting room, and it talked about Pesticide Alley, 99 being the Pesticide Alley, and most of my circle of friends, I've had 5 people die of Parkinson's within the last 2 years. And so I'm just wondering, why do they have to go to LA? Why do they have to go different places instead? Why don't we have a facility here in the Central Valley to deal with that issue? Sort of like the Cancer Institute. We could have a Parkinson Valley Fever Institute. And then the issue of transportation for specialty care from the rural areas to the big cities is a really big problem. I'm on Measure C if people want to join me. But I'm really concerned about those issues, especially as a founder of Líderes Campesinas, we saw the increase of breast cancer as it relates to pesticides. So those are my concerns.
Thank you for that question, and that hits home for me. My abuela had Parkinson's and worked in the fields, and that connection has been made before, so thank you for that. Anyone want to touch on that?
Yeah, I'll jump right into that. I think the lack of specialty. So neurologists will be the specialty physician that really is the tip of the spear when it comes to setting up a Parkinson's clinic. We have a paucity of neurologists in the Central Valley. So we at QUIA are actively planning and been for a few years now of starting a neurology residency program locally to help train up local neurologists to stay. We've been actively recruiting for neurologists to come to the Central Valley for years, along with GI and urology and all the subspecialties that we're challenged with. At the end of the day, the best way to get physicians here is to train them here. When they spend 4 or 5 years here and they meet somebody and get married, Lord willing, and set up a little dating service, I don't know, whatever we've got to do to keep them to stay. But, people don't typically come to the Central Valley. It's not the beaches and palm trees. But when they get here and they realize, you know what? The cost of living is like the Midwest. I get the California rate of pay. LA is an hour and a half away. I can get to the beach on a weekend if I want to, and I'm busy. They stay. So we've got to increase our GME programs and train up physicians to train here and stay here.
I think we have time for maybe one more question. I see Diana's got one in the corner.
Oh, hi, Tanya Pacheco-Warner, Central Valley Health Policy Institute. The survey mentioned people worried about extreme weather events, and I'm just thinking in terms of the emergency response infrastructure that you set up during the pandemic, how much of that do you see that still needs to be held up, or what are opportunities that you see for infrastructure to still exist to respond to extreme weather events or other emergencies, even as we know, everyone is saying, right, the next pandemic?
God forbid.
I believe it still needs to be stood up. I mean, from a health plan level, when we get the alerts, we're still always going to activate our emergency and contingency plans, try and reach out to connections, reach out to partners, reach out to our members to see if they need help, try and divert resources to them if needed. So I believe it's something that's still going to be needed and something that we're still going to be activating within our organizations.
Yeah, I think the benefit of what we've gone through COVID is, I think any organization of size has a level of expertise and a network now and a collaboration with, county public health and the clinic systems. And I mean, we really came together in Tulare and Kings County in a way that we never, ever have in the past. And now I'm on a first name basis with leadership from other organizations. And so we have the ability, I think, because of that, to stand things up when needed in a more efficient way to meet the needs of the community, for sure.
I'll just add that there is an emergency response team that is made up of individuals from different organizations that meet on a regular basis to talk about disaster preparedness. I'll echo what Ryan said. I think the pandemic really brought us together. I see Sarah Boss here. We worked very closely with her and Dr. Simon Paul as well in just formulating our response efforts to the pandemic. And I think those relationships are ones that are going to continue, and we're going to continue to strengthen and try to work on those very topics, such as you're talking about weather, the impact of weather and other climate-related conditions.
Great. Well, I think that probably brings us to time, and I want to just acknowledge that one of the big themes I heard through this conversation was trust and collaboration, and a lot of that got forged during the pandemic, so let's not let that go to waste. So with that, help me thanking our panelists for being here today.
Well, thank you very much. Thank you, Diana, on that first panel for just a very engaging, insightful discussion this morning. And we have on tap a really great second panel providing some community perspectives around challenges and opportunities here in the region. I am just so excited that Crescencio Rodriguez-Delgado from KVPR is here to moderate this second panel. Crez, for those of you who know him, has worked at KVPR, the national public radio affiliate station here, of course, in Central California. Prior to KVPR, Crez was a correspondent for PBS NewsHour. Certainly have seen him or saw him take place in a number of important discussions on that program. And before that was a reporter for the Fresno Bee. Crez, I will turn things over to you to introduce this second panel, but everyone in the room, please join me in welcoming folks here for our second discussion.
Thank you so much, Christoph. I appreciate it. And good morning, everybody. Thank you so much for being here. I'm actually going to have the panel introduce themselves. Really briefly, we'll start with Kimberly.
All right. Okay, it turns on itself. I was a little nervous about that. Thank you. So I'm Kimberly Clark. I'm the Director of Programs with the California Farm Worker Foundation. We are a nonprofit that kicked off in Delano and serves Kern, Tulare, Fresno counties. We also get a little bit outside of our area here over into Santa Barbara and Riverside counties. And since 2016, we have really just focused on serving our farm workers, and I'm already going to do the catchphrase, meet them where they are. I was already mentioned in the previous panel. And we focus on bringing resources and services to farm workers, focusing on health, wellness, education, and really trying to tie in those wraparound services, everything from literal nutrition from food boxes, but also the education component in a culturally and linguistically appropriate, I think I'll transfer over or do a little intro there, also to immigration services and just all the different, trying to serve all these different areas. But of course, without your health, you have nothing. So we've been really emphasizing the health and wellness aspects, particularly in the last couple of years here. So I'm excited to hear from the rest of our panel as well.
We'll go to Sarah next.
Hello, my name is Sarah Boss, and I'm the Public Health Director for Madera County. I've been working in public health in the Valley since 1998. I was about 10 years old at that time. And My expertise is really in policy and systems change, and specifically around chronic disease. But in the last 6.5 years, being a public health director, I've become an expert in communicable disease, I've become an expert in emergency preparedness, and certainly with the closure of the hospital, I am in the process of learning more and more about issues regarding access to care. It's really become a passion. I'm so excited to be here today. Thanks.
Hello. All of you who've been to a Mexican quinceañera or wedding know this. Sí, uno, testing. I'm Genoveva Islas. I'm the executive director of Cultiva la Salud. We're a public health advocacy organization. We're interested in promoting good health, in particular among disadvantaged community members. I also wear another hat that I'll just acknowledge quickly, and that's as a trustee for Fresno Unified School District. And I also just want to say hello because I feel everybody in this room is part of a tribe working to promote the health and well-being of our community here. So good to see you all.
Great, and welcome everybody on the panel. As I was thinking about where to start this conversation, I mean, there were so many places where we could start, so many things to touch on and to talk about in healthcare. It's such a important topic. I want to start by talking about this this website that exists that it's called the Cal EnviroScreen 4.0, and I'm sure all of you are familiar with it, and I'm sure a lot of you in the audience are also familiar with it. Essentially, it shows us what are the areas of California that have the biggest struggles when it comes to determinants of health, and whether it's healthy or not. And the first time I saw that map, I could not unsee it. It scared me. And so the reason I bring that up is because I want to ask you all to talk about how do healthcare challenges show up in your field? Because when you look at that map, we know that they exist. And so, Veva, I'll start with you if you can answer that question first.
Yeah, well, first let me just acknowledge Cal EnviroScreen as a tool because it has been really useful in helping to describe, visualize, if you will, what all of us in the Central Valley know based on our lived experiences here, right? The magnitude of health inequities and disparities that we have to live through. And also, if you're in public health, it's a tool that often gets referenced in grant applications, like you have to, pick an area and describe it. I think that, in our work over the years, we began as a childhood obesity prevention initiative, and it really magnified how it is not possible for a child or a family alone to control their health and their well-being. That it really is about the places where they live, learn, work, play, that have profound impacts, right? And so as a public health advocate, I will say that there is a lot of investment that we have to do in promoting prevention within our communities, in keeping people healthy, right? Ensuring that they have access to healthy food, safe places to play, and of course, access to healthcare. So this report for me confirmed, again, what we all know, what many of us knew. It's really great to put it into print and to give us something that we can share and help to elevate with key decision makers who have control over these policies and systems and environment that impact us.
We'll go to Sarah next. Do you want to respond about your impression of the Cal EnviroScreen and how does that translate to the work or to the challenges that you see in the healthcare industry?
Yes. For those of you who need the map, it's actually on your tables. This handout right here on the second page, there's two different maps. So one is Cal EnviroScreen and the other is Healthy Places Index. And what they do is they really visualize for us what we do intuitively know that is different in Central California than the rest of the state. And I have had that experience my entire life of you travel outside and everybody thinks that California is San Francisco, LA, and San Diego. If you had that experience when you're traveling, and then you have to describe how it's different in the valley. And it's truly a stark difference that we experience. I think it's really telling to the fact that it is about a whole host of environmental considerations that people are faced with on a regular basis. But it also, I think, highlights the importance of us working regionally and not in silos, because both geographically and in terms of disciplines, it's all a web that's very connected together. And so I'm looking forward to, and experiencing even now, more regional work highlighting the very specific, unique qualities of this region that need to be addressed from an equity perspective differently than the rest of the state. And so I would encourage you to be able to kind of walk through some of the differences that you can see in this snapshot tool on the front page. You can see when we talk about workforce shortage, which was mentioned in the last panel, we're not talking about a small workforce shortage. Our providers, by discipline, you can see there, it ranges between 45 and 55% more patients per provider. And I thought about this from a perspective in terms of if somebody walked in and said, okay, tomorrow, you're going to have to handle 50% more work than what you're handling today. Would I be able to keep up with that? Would I be able to do quality work, have quality outcomes, give people quality time, be able to pay attention to the inequities between the individuals that I'm interacting with? And the answer is no. It's not actually something that providers can do in a real way. And we need to be looking at some innovative kind of solutions for that. And then you can see it in the health outcomes, that healthcare access is one layer in all of these other layers, but our diabetes rates are 15% higher than the rest of the state. And this one really concerns me. It's the very bottom right-hand corner of that handout, and that's infant mortality. Because it is a canary measure. It kind of absorbs all of the factors that we're talking about and reflects it in a single outcome that we can see with our youngest and most vulnerable. And it's 37% higher in our region than the rest of California.
Do you want to share anything on that, Kimberly, on just those social determinants of health?
Yes, thank you. First, I think I'm probably going to say this a lot. Very much agreed with all your points, and I appreciate you for bringing them up. From my perspective, I come at it a little bit differently in that it's an excellent tool, and it's a great resource, but it's a tool to have those conversations and make that analysis, and we need to be making sure that, great, we did the report, we got the numbers, and then what? What did we do with those? And hopefully these conversations move that forward and get us closer to focusing on what we're gonna do next to change those numbers. So I love looking at it and having that information. It gives a frame of reference, but as we've all said, and you all probably agree, most of us weren't surprised. This wasn't new information to most of us. Again, excellent to have that quantitative data to really back it up and help those grant writing, I agree. But from our perspective, working with farm workers day in and day out, taking it from the 30,000, 10,000 foot view and remembering that these are individuals. And it's very important to know what the rates are, how they're different, and how we need to address it. But at the end of the day, remember that these are people. And I'm preaching to the crowd here quite literally. But we just had one of our community events where we had a clinic, and we had someone that went in and got their blood pressure checked, very basic, and it was through the roof to the point where it was a crisis situation for that person in that moment. And so it's one thing when we look at these numbers, which I'm a data nerd, I love looking at them, but we also have to remember that what's the individual story for these people? And then hopefully treat that person, that individual, and review the numbers at the end of the day. Hopefully we can come back a year from now, a few years from now, and not only see what the new numbers are, but compare them to the current ones, again, using this fantastic tool.
And as someone already mentioned that, looking at that tool, a lot of the results that were out in this report reflected that. And so some of the numbers that stood out to me from the report was the fact that 6 in 10 people delay care due to cost. That is a high number. And that number is actually higher in Central California than it is in other parts of the state. And so many of them think reducing the cost of healthcare is very important. I think that was mentioned in the last panel. A lot of them think that there aren't enough providers. And so a lot of this has to do with perspective of people. How do they view the healthcare system? So I'm curious, based on your interactions with people in the community, what do you hear as far as how they view the healthcare system? And we'll start with Kimberly.
Some of them don't. They don't really look at the healthcare system. It's not the top concern on their list. And again, coming from the farm worker perspective, that there's a lot of things that are come a lot higher. You know, when we talk to people and say, oh, you know, just make an appointment, come on down, no worries. They say, how am I gonna get, you know, on the previous panel, how am I gonna get there? Who's gonna watch over my kids? I'm gonna have, if I have to miss work, that's lost wages. And so unfortunately, for a lot of them, we still see that it's not, there's too many other things that are too important for them that it gets bumped down, which of course long-term has unfortunately catastrophic consequences. For those that are a little bit more engaged with it, there still is that trust issue, absolutely. I love that we've already brought up promotores a couple times, that's fantastic. And I would say for the people even beyond that who are really trying to engage with it, and I'll say personally, myself, it's complicated and confusing, and it's a pain. So I will say we do have some positive experiences. We definitely have people that talk about having great interactions with their care providers, so there are some positive stories as well. But across the board, it goes from just not putting it on their priority list, not being able to manage a system that's so complicated and it's not built for them. And then cost too. I'll leave it there. I'll pass. I'm sure we have more to add.
Sarah, do you want to go next?
Sure. I think people are delaying care due to cost, as the survey found, but they're also delaying care due to a whole host of other challenges, as we have mentioned. And a lot of people have come and asked, like, what are the outcomes that you're seeing from a health perspective on the closure of Madera Community Hospital? Because there were so many specialties that were included in the rural health clinics, access to a labor and delivery and emergency department in particular. And we have heard lots from the community about individual stories of people's experiences with regards to not being able to get to the health care that they need to get to and making tough decisions about how they're going to spend their time. Do they go ahead and get to that preventative health care visit or get to their dialysis treatment, or do they prioritize their limited funds not on that transportation but on buying groceries? And those are difficult decisions to make. And my own experience in the healthcare system confirms how difficult it must be for someone who doesn't have the privileges that I experience with the health insurance that I have, with access to transportation, with resources, flexible schedules, sick leave, all of those things. If I'm struggling, then those who don't have access to those same resources are in a really different place. Because I had a healthcare experience in recent times in which it was something I absolutely needed healthcare for. Diet and exercise and preventative care was not going to prevent me from getting a kidney stone. I had one. And by the time I was done, it was 2 surgeries, 2 ER visits separate from the surgeries, and 6 transportation visits to the doctor. 2 of those were just to schedule appointments because they didn't pick up the phone. And the whole time I was thinking, what if I was someone who didn't have a car? What if I didn't have sick leave? How would I be able to navigate what would actually have been life-threatening to me if I was any of hundreds of thousands of people in our community that struggle to be able to access care? It's a broken system, and we're trying to fix with some of the puzzle pieces and not the entire puzzle.
So I'll preface this response by saying that I am the granddaughter and daughter of farm workers who grew up in poverty. One of my primary roles starting at the age of 12 was being the interpreter for my family during healthcare visits. And I'm seeing nodding heads, so I know a lot of you are relating to that. It was not unusual to witness family members being turned away because they didn't have health insurance. It wasn't unusual to witness family members reserving when they had medications because they didn't know when they'd be able to afford to get them again. I learned to give insulin injections when I was 12 years old to my Tia Maria, my beloved Tia Maria. She struggled with diabetes, and she ended up losing her toe, her foot, her leg, and eventually her life. Delayed care is delayed treatment, and it's premature death. And that is, unfortunately, a very common experience for disadvantaged, low-income community members, but our population in general, as Sarah has just mentioned, right? Like, it's not just affecting us, but it affects us profoundly. I appreciate this report calling out the fact that we, as Latinos, are 57% of the population, right? 57%. For the first time, we're seeing reports that call out our experiences specifically, and I appreciate that immensely in this report because that does not often happen. But I also want to say this, that in order for us to get this report to materialize into something that's a change, it takes all of us collectively to work on it. We are 57% of the population, but we do not represent 57% of the voters. We are not exercising our voting power to demand change, and that's something we have to work on and work on deeply. I think that we can no longer afford to see our family members succumb to preventable illnesses. I think that we have to demand that we have access to good quality care. And it also means something in addition for me, as I think of my school board hat, that we have to create the pipelines that change the trajectory of what it means to live in a provider shortage area, right? The more often and frequently we can get our own children involved in healthcare, whether it's nursing, being a doctor, that has to start very early, and we have to have the training institutions here to keep them here. But the other thing I'll say is that we have an immense workforce of community health workers who are ready to go to work and who are doing amazing things. Those community health workers can help our community navigate the systems, whether it's systems of insurance, whether it's access to healthcare facilities and services, whether it's mental health and mental health resources, right? Or bridging to the resources that can help keep them healthy. All of that is necessary, and we have to have the infrastructure that supports it, that finances, that makes it function better.
Sarah, I want to go to you with this next question. What is the impact of the provider shortage? We know that more people, there are fewer doctors for more people in this region. And what is the result of that? And how can we fix that?
How can we fix it? Wow, that's the question of the day, isn't it? The impact of not enough medical providers is, as I've described, we can all relate to. If the workload is much higher, they're going to have shorter appointments. They're going to be rushing people through things. They're not going to be able to afford to do those managed care behaviors that Dr. Ramirez was talking about, where we're excited about managed care and the idea of managed care. But if you don't have, if your patient load is too high, it's going to be too difficult for you to be able to track that your patient was in the hospital and you need to follow up with them, or that your patient hasn't refilled their prescription and what's going on. Those are things that take time and intentionality that when the workforce is short, those individuals are not going to be able to do that. Now, community health workers is one big part of a solution to that. It can kind of take the ability for a physician or a nurse practitioner to be able to do those social determinant kinds of checks and those relational things with patients. And that's something that can happen much faster than medical pipeline sorts of solutions can solve. I do think that we need to look at some kind of bold innovation strategies. And many of those are going to require coordination with the state and the feds to be able to look at what are the opportunities for bringing in medical professionals into our area for the short term while we're trying to build up the pipeline for our workforce. and we're trying to, again, I keep talking about the big puzzle, expansion of Medi-Cal was a huge puzzle piece. There are a whole bunch of people now. They have a ticket to get into the show, but the seats are all full. And so we need to have more seats at the table to be able to really fill out the picture of access to care. And we at the Central California Public Health Consortium that has been working on a lot of these data tools have been working with the state around how do we do some targeted investments, even piloting things that are unique and disproportional investment into this area to be able to see what works and pulls those levers on increasing workforce here.
And I'm curious, could you give us an example of how does managed care look like? I mean, when it's working well and somebody has access to it, how does that look?
Managed care is, how many of you have an HMO, health plan? Okay, it's a lot like that. It's anchored in a primary care provider. And the idea is that primary care provider knows you, gets to know your needs, understands your social determinants, your transportation challenges, where you go to get your medications, whether or not you have different sensibilities about healthcare, values about healthcare, what's your cultural background, what are your language needs, all of those things. And it's anchored in that primary care provider. And then if you need specialty care and other types of care, it's coordinated through that primary care provider. And they are charged with knowing what those things are and whether or not you're following through with those appointments and looping back. So CalAIM, through Enhanced Care Management, is trying to enhance those managed care sorts of behaviors with supports of case managers, basically community health workers, who are helping people get to those appointments, making sure they're following through with the treatment that's prescribed, but it anchors into that PCP.
So very personal, very involved in the process. But we know that doesn't exist for everybody. And so Kimberly, I want to ask you this next. Through the foundation, the Farm Worker Foundation, you guys go out and do farm worker clinics, health clinics. Can you talk about what happens at those clinics? And I'm assuming it's people who don't have this kind of care that Sarah was describing. So what happens at those clinics and what do you hear from people?
First, I love your metaphor of you've got the ticket, but there are no seats. And I'm going to push even a little bit more and say when we do shove more seats in there, if we're not increasing the capacity to serve, what airline are we flying and how far back on the plane are we, right? If your first experience flying on a plane is first class, that's probably pretty nice. If your first experience is flying with, I'm just not going to mention any names, but I think y'all can guess. If that's your first experience and you're smushed in there and you've got your knees up, then you might not be inclined to take the next flight. You might try to find a different way that might not serve you as well. So I'm going to steal that metaphor as well. Thank you. So when we are going out to the field to try to bring the services to farm workers, to quite literally meet them where they are, we've seen different interactions, right? And so some of the times when we've gone out, because we work with a lot of different partners, which is, again, a key, I think we're all referencing this again, the key is really making those strong partnerships and making sure that they work for the end user. With some of our events, we had some clinics where they set it up, it's all nice and pretty, they say, hey, here's the services we've got, just come on by. Nope, come on over, step on up, these are the services. And some people do engage, and that's great. But we have noticed a very marked difference when we send our staff out to say, buenos días, mi nombre es Kimberly. Actually, it's not me, I'll admit that's my staff, they do the great work there. I get to see them doing the great work from the sidelines, but they go up and they interact with the people as individuals and make that connection. And through that, they're able to just start a human interaction, honestly. It sounds really basic. I feel a little silly highlighting it, but just recognizing them as, hey, we're two people here and we're just chatting. And from that little connection, they can then build up, get a little bit more context, a little bit more information on, hey, what are they actually doing over there? And why should I? Why should I take time out from my lunch? Or actually a lot of our partners will even pay their time, which is fantastic. I have a whole other diatribe on that. But even so, when it's right there in front of them, their time is paid, we're really cutting back on those direct and indirect costs, people still are sometimes slow to engage. But having that individual, that human connection, to be able to really well connect with them and show them what the importance is here and how it can really impact them, that's really made the difference. And so when we have our staff that is out there connected with them, we see way more people that are going through and are able to get those services, which I think transitions perfectly to this point we've been emphasizing about using community health workers and promotoras.
Yeah, and I want to touch on that with Veva, but I want to follow up on the experiences with the farm workers. I mean, sometimes, what are you finding with them that they need immediately as far as healthcare needs?
Yeah, thank you for that highlight on that, because a lot of these times we're talking about really big picture, long-term, very important topics, but sometimes we lose the things that are a little bit more urgent, right? Without your health, you have nothing. And while we are having these conversations about mental health, which is critical, and I'm so glad that we are having more people that are aware and talking about it. We have people that have diabetes, hypertension, it's through the roof. It is at critical levels, and people don't even know. Sometimes we do have farm workers that come in, they're kind of aware, well, a few years ago, I went through some clinic, and I don't really know, haven't followed up. But we've had people that have no idea that they are walking around with a critical health issue that could, maybe a little crass, but it's a time bomb at a certain point. So yeah, when we're looking at diabetes, hypertension, and cholesterol, these are, for a lot of people, it's almost basic. Oh, we know those are problems, but they're still not being served at that level.
And I'm assuming this is what community health workers are finding out as well, Veva, when they go out in the community. I want to ask you, when you started your organization, Cultiva la Salud, what was the reason for that, and how have you seen healthcare access and also conversations about healthcare evolve over time? I mean, have they improved in your view?
Yeah. So Cultiva la Salud was established in response to the childhood obesity epidemic, right? Like that's where we first started. And I think it was really interesting to learn again about how our housing policy, our park and recreation, our land use planning, our development code, our economic development, all have profound impacts on perpetuating poor health, or in the reverse, addressing it. And so I just want to put a plug in for the importance of prevention. I think sometimes we think about healthcare in absence of prevention, and both are needed. Both investments are really important. I think, when I was listening to Sarah respond to managed care, for me, managed care is a system that responds to my needs. That's managed care, right? That I can count on, that I can depend on. When I was hearing Kimberly talk, I was thinking about, my lived experience being a 12-year-old, having to interpret for a godfather who was diagnosed with testicular cancer. Can you imagine how uncomfortable it would be as a Latino male having to depend on a 12-year-old child, a woman, a girl, to tell you what the doctor was saying? Would you be comfortable sharing with that interpreter your discomfort, what you were feeling, what you needed, right? And I think, unfortunately, those type of scenarios, maybe not as extreme, but in many ways, those type of scenarios still continue to play out. And while I'm grateful that we've enacted class standards and that our healthcare providers are required to provide, language interpretation, either through a phone or in person, nothing replaces the importance of being treated with dignity and being treated with respect, right? And I think when you read this report, one of the things that is really revealing is how, for the Latino community, the absence of having a doctor that speaks your language, the absence of having people who can relate to your culture, your norms, the absence of being able to afford that, right, and what that means and how that plays out, like these are really profound things, and we need to find better ways of serving. Community health workers are better ways of serving. Community health workers are navigators, they're emissaries, they're advocates, they're translators in many instances. A lot of the experience of our community health workers presently, who are actually working thanks to funding from our health department, shout out to them, addressing health disparities. We're also part of the HOPE PCH network, and my community health workers are amazing, right? And the type of thank you letters and gratitude that we get from community over simple things like connecting to food distributions, connecting to clothing so that they can have a suit to wear for an interview for a job, helping them connect by developing resumes, by supporting their transportation from rural communities to access care, right? Like these are all things that may seem very simple, but if you don't know, you need somebody who knows to help guide you. And I think in many ways, the weight of the burden that our community health workers experience when there is no affordable housing to refer people to, when they can't do anything about the weight of an appointment that they have to travel out of the valley to get 3 months from now, right? Our systems are broken, and they're broken in very profound ways that we've already discussed. The cost, the accessibility, the availability, but we haven't really talked about acceptance, right? Not just acceptance of your health insurance, but acceptance of you and your needs. We woefully serve people with substance abuse disorders, with mental health disorders. If I wanted to refer, I think maybe Dr. G might be one of the only shops in town where I could refer somebody who is having mental health crisis to. But what if you're living in the remote areas of Fresno County, right? Like, are you gonna be able to drive in every Wednesday for your hour appointment with your marriage family therapist, right? Like, there's a lot that we need to do to invest in, and I do think community health workers can be some of the frontline workers to help address these needs, training them in emergency mental health response, training them in applying for Medi-Cal, training them in supporting community in all the ways they can. Our communities deserve it. They deserve greater access to care. They deserve to maximize the resources that exist, and oftentimes there's language or cultural issues that can impede that. And so their role is immensely important for us.
And so these community health workers have obviously become part of this ecosystem, this healthcare ecosystem. They're part of it, right? I mean, there's hospitals, there's physicians, and there are the community health workers. Sarah, I'm curious from your perspective, when we see sort of the growth of these community health workers in communities, a lot of them are getting to understand the community a lot more. Are we seeing sort of a change in sort of the landscape of healthcare, how people approach healthcare from a public health perspective, in terms of how people feel more comfortable getting healthcare and asking for help? I'm curious, is this a model? Is this something that can grow? Is it already growing? What are your thoughts on that?
So community health workers, in terms of really having them institutionalized in our healthcare system, there's a lot of work to be done. At this point, there are model programs, and they're really starting to be able to dial into the data to understand the impact and be able to show the value of the investment, to be able to increase the rates for community health workers to truly cover costs and things like that. And so we don't quite know from a data standpoint. We know intuitively. We can see the individual stories. We can understand the outcomes of individual patients and the outcomes of community health workers as part of that system. But to quantify exactly what that looks like is still in process. And so I think it's important for those who are leading with models. Certainly Fresno County has a model that is leading the way. Riverside County has another model that is really pushing forward from a community health worker standpoint. I think that we also have some work to do in the institutional healthcare system for them to understand and value community health workers. And so those physicians that are champions that have been working with community health workers, and they can see the positive outcomes with those patients, we really need to pull them in to be able to help educate the rest of the providers to understand the real value so that they can kind of leverage their power to increase that resource.
And I want to make some time for all of you to share some positive stuff, because we know the report outlines some unfortunate findings, and all of you are very familiar with that. So I want to start with Kimberly. What is something that inspires you, or something that keeps you going, and as far as the work you do with the Farm Worker Foundation and addressing healthcare needs? What is something that's working right now?
Ending on a positive note, I like it because we do get a little doom and gloom here. The fact that we're having this conversation, that we are talking very actively about building partnerships and really focusing on the end user of how do we meet them where they are. We can't just keep saying, oh, you just come to us, come to us. Why aren't they coming to us? They're not coming to us. And so the fact that we're having these conversations and that we're finding more partners who want to make these connections so that we can better serve the most underserved, as well as the medium served and even the high up, right? We could always benefit at every level. So the fact that we're having these conversations and people are trying to make these connections and these partnerships, that's awesome. I love hearing about that when people get excited about it. And then even more than that, I love seeing farm workers in the field who are being served, who are able to go through for the first time in years, if ever in some cases, and actually see a medical professional and being able to talk with them. As much as, yes, translation services are excellent, there's something lost there. There's always something that you lose a little bit. So being able to see them go through and have a positive experience and come out of it and say, oh, they told me that, here's some of my issues, and some of our partners actually have pharmacies that are able to come out on site, and that's fantastic, because we didn't even get into that of, if you don't have a hospital, do you even have a pharmacy in your area? And I've had some people try to mail me my medications, and I'm even kind of weirded out by that. So I can only imagine for others who don't have necessarily a safe place they can have them mailed. But being able to see them go through this and come out the door with a better understanding of their personal health and what they need to do to improve or maintain that health, and have their baggie of, I've got my prescription and I know where to go at the end of the month when I need a new one, that's really uplifting. So seeing that we are making some progress, albeit slower than we'd all like, of being able to actually meet these people where they are and serve them, addressing these direct costs and the indirect costs, and how we can bring that rein that in a little bit to make it easier to access care. That's what I'm seeing the benefit in here. And of course also the wraparound services that we're talking about. We both mentioned access to food, nutrition, education, the fact that we're coming at this from a more holistic view and realizing that, wow, everything is really connected in your body. We do have to address the physical health issues along with the mental health. So seeing that we're having these conversations and then out in the field being able to start seeing that actually be implemented and seeing those outcomes for real individuals, that's my positive note. So.
And we have 3 minutes, but I want to make sure I get to both of you. Sarah, do you want to share what positivity are you seeing in the healthcare landscape?
I'm really encouraged by actually having public health on this panel, because it wasn't so many years ago that public health would not have been included in the conversation. But I think COVID really ushered in an era of us really understanding the interconnected aspects of the health of the community, that it's based on the built environment and the economy and all of these social determinants of health. And I'm really encouraged by the transformation of how we're thinking, so that maybe we can get to a healthcare system instead of a sick care system.
I think we've touched on a couple of things that I'm excited about. Certainly the establishment of community health workers. They need to be paid well, they need to be benefited, they need to be sustainable. And models that simply pay for community health workers through grants are not enough. We need systems of reimbursement that can sustain them over the long haul. I'm very hopeful about the expansion of Medi-Cal and totally agree that sometimes having a seat at the table doesn't mean you get the full course. Our communities deserve the full course, and more people in the Valley are uninsured than anywhere else. They are the working poor who may not qualify for Medi-Cal eligibility. So we still need a lot of work to expand that. And yes, I'll acknowledge that we still have a long way to go to building the pipelines of providers, whether it's mental health care providers, where it's physicians, but the whole gamut of our healthcare system does need to be shored up in many ways. I will say that there is a lot of work that we still have to do to address the diversity, equity, and inclusion that our communities deserve, right? Having providers, again, mental health, healthcare, who speak the language of the population, who understand the cultural and linguistic needs of our community is really important. And in order for us to bring that to fruition, I think we need to invest early. We need to have pipelines of opportunity for kids here in the Valley. We need to have education training programs here in the Valley so that our children, our youth, can stay in the Valley. We need a doctorsmatch.com so the doctors that are trained here will stay here. I say that joking, but in full seriousness, right? Like finding a love interest is something that can help keep physicians in the Valley. I do think that we need to hold the people holding the purse strings to the full breadth of our healthcare system responsible to addressing the needs that our communities have. And the one way we can do that is creating seats at the table for those same community members who experience the disadvantages. Nowhere in history have we solved the issues that are impacting us without including the most impacted. So again, I think, just to echo my earlier call about the importance of being engaged, we need a healthcare system that creates spaces at the table for the communities they're serving and listens to their needs and addresses them.
Great. So more pharmacies, creating a healthcare system, not a sick care system, and more opportunities in healthcare. So I'm sure those are all points that are going to be well received. So really appreciate all the responses to my questions, but now I want to turn it over to the audience. If any of you have any questions for our panel, each of them have expertise in their respective areas, and I see some hands going up, so we'll walk the microphone over.
I got permission from Christoph, but so inspired by what you're doing. I would really love to connect with each one of you and anybody else in the audience who would love to join a collaborative that we have established to advocate to the state to add farm workers as a population of focus to the CalAIM program. We have a meeting next Wednesday with Dr. Paula Babadia, the Chief Quality and Medical Officer at DHCS, to discuss this very issue. And we'd love to add a lot of names of your organizations to the list of everyone behind this effort, and working with UC Berkeley and Merced Farm Worker Study as well. So we're going to be standing up here in the front, and please come connect with us, and we'd love to add you to the collaborative. Thank you for your work.
My business card's on that table behind you.
Hello, my name is Nasreen Gusby. I'm with Tulare County Public Health. Thank you for all of the work you're doing, and thank you guys for all the organizers for putting this together. I did have a question. One data point that I came across recently is the percent of medical debt and collections. So our counties, Kings and Tulare, were one of the top 2 in California, and Fresno was in the top 7. So other than the obvious of working on policies with healthcare facilities to change their debt collection practices, is there any work being done with community members to educate them once they get that bill on what steps they can take to hopefully stay out of that and not ruin their debt, getting something on there for the next 7 years or so?
Anybody want to take on debt?
We don't have anything quite in the area of debt. Unfortunately, I'm glad that people are paying attention to it, because this is actually, we often run into people who, speaking of delaying care, they'll hold off, they'll delay until it's an emergency. They go to the ER, and when they get that bill, they're not engaging again in the future, right? So not only is it the debt itself is a problem, but that's also inhibiting care into the future. And so for a lot of people, if the ER is their only frame of reference, they think healthcare is even more expensive, right, if they were going to preventative cases. So most of our focus on that has been trying to, on the front end, get them the preventative care and get them into Medi-Cal or other systems that can help that on the front end. But unfortunately, I don't know if anyone else could speak to the debt issue in particular.
So this is a roundabout way. Like, of course, we need to refer people early before they have crisis and enroll them. More people need to have established medical homes so that they're not going into the emergency room. So it's the advantage of having a community health worker workforce that can direct people to places of care early on and not waiting till they have an exacerbated health condition. But, you know, I would say that there's a lot in our society that needs to change. We need to stop treating people living in poverty as being totally responsible for their care. We do need to have greater access to opportunities for them to lead healthier lives so that we can prevent the onset of chronic illnesses. And I think that we definitely need to consider universal basic income and how we create greater equity across community members so that they can afford to access the care that's available as well.
Hi, good afternoon. My name is Sonia Duran Aguilar. I'm the Director of Population Health at COIA. I am just in awe of all of the information you've shared. I wasn't surprised by the survey results, but I did want to make a comment, and maybe if there are other people who love data in the room and you have found a model, I would love to hear more of it. But how many of us in public health have ever heard the catchphrase, if you can't prove what you've prevented, how do you fund it? How do we fund the savings? How do we fund these programs? So in the case of community health workers, I have heard it said, our organization is very supportive. We have a team of community health workers. But how many times have we heard, how do we prove how much cost savings? What's the ROI? How many ED visits did they prevent? So I would love to hear, you know, if there hasn't been a formula developed for how do we prove that? How do we, aside from the stories, because you mentioned that each person is a data point, and we have many success stories, but when we look to advocate to fund these programs, we need to be able to have a robust cost savings ROI. It's not about the money, but in a way it is. So if there's a way, if there's a model for us to implement that, if not, we need to develop one.
So I'll just add to your comment. It's been kind of the challenge of public health from the very beginning. When public health is doing a really, really great job, people don't see an outcome that's motivating. And what you've seen over time is that when we invest in programs that prevent sexually transmitted diseases, the rates go down. And then as soon as the rates come down, they cut the funding and the rates go back up. We just went through COVID. And we recognized collectively the disinvestment that had happened in public health over decades of time. Future of public health dollars were put forward in the state of California following COVID to rebuild our public health system. And those dollars are slated for elimination in the May revise that came out last week. And that's a year and a half later because it's not compelling. It's exactly what you're speaking to. So I think that we still have a lot of work to do in public health, and we in public health. I like to play a party game. You tell me something you're interested in, and I'll tell you how it's public health. So we are public health all together in the room, and I am excited about the progression of people's thinking, but it's not, we haven't gotten there yet, because we still come to the place that when things are going well, we cut the funds that have created those positive outcomes. there's still a lot of work to be done.
So we have time for at least one more question.
Yes. Well, good morning, everyone. Thank you to our panelists for the stimulating discussion, provocative discussions. Thank you to California Healthcare Foundation for setting this all up. I wanted to share some information. I'm Dr. Chung. I'm the Assistant Dean of Graduate Medical Education at California Health Sciences College of Osteopathic Medicine. We would love to collaborate with all of you here in the Valley to make an impact for the Valley. The mission of our school is to cultivate, going back to, and echoing your sentiment with pipelines, cultivating physicians who are from here to build upon the growth in the healthcare for access in the Valley. So this graduating class, up to 65 students, we have more than a third who are from the Valley, staying in the Valley, some mental health specialties as well. Very proud of us to help. If in any way we can give back to you guys, collaborate with you guys, please let us know. I have my contact information here with my team members here as well. So I encourage that discussion further. The other question I had for you, I'm seeing a lot of health networks and clinics building mobile clinics. I was wondering your take on that and how that can impact care for the Valley.
I'm going to jump on that one right away. Mobile clinics have been fantastic. It is literally meeting people where they are, and it jumps up over a lot of those indirect costs that can be huge barriers, while, again, we might think they're smaller. One of the issues we're running into with the mobile clinics is the staffing. So there are places where there are beautiful, they've got the great vans that can take multiple people. They don't have enough health workers to staff them. So yes, please, on the health clinics, but it loops back to your own question or your own comments that you've shared, that if we don't have the staffing, it's just a pretty bust at that point.
I'll add also that I love rural mobile health clinics, and I think they've created a huge advantage in our rural communities. I think part of the issue that we have to understand is that our community members do not have a lot of access to technology, and that lack of access to technology also limits information. So we have to create the regularity of these rural mobile health clinics going out so that people can take advantage of them. We've partnered with many groups doing rural mobile health clinics and had our community health workers going out there, and repeatedly we hear, oh, yo no sabía que iban a estar aquí. I didn't know you guys were gonna be here. I just kind of stumbled upon you. Right? And we need people to know and can count on it being there regularly for it to be a real way to continue to get access to care.
Great. I think we have time for one more question, actually. So I see somebody with the microphone over there.
Good. Oh, okay. Sure. I want to thank everyone, all the panelists, and earlier, Mr. Nkasa, I think you're the only one still here. Education, my name is Robert Mitchell, born and raised in Southwest Fresno, still live in Southwest Fresno. Number one, Brookings Institute has us as number one in America in concentrated poverty. And scrolling through the New York Times at the end of the year, 2023, we made it again. West Fresno was cited as the one place that had a 20-year difference in lifespan compared to North Fresno. All right. So there was a word used during the first panel, weighted, a weighted approach as we speak to the infant mortality. You know, we're 7, maybe 7%, but that's 50% of our community there, African American. What kind of weighted approach do you foresee taking to reestablish an approach to support? I always say education, poverty, healthcare, that triad. Okay, education-wise, 11th graders, African Americans, they're at 6%. There's 6% of them on par at 11th grade in mathematics, and only 20% reading. They're not gonna make it to the pipeline. They're not gonna make it to medical school. I'm one of the last ones in 93706 that still live there. We had the first cardiovascular surgeon in Fresno that lived in South. We had the first OB-GYN resident that lived in Southwest Fresno. So thank you.
So, of course, I'm the director in Madera County, but I worked in Fresno County for a long time before I became the director in Madera. And what you're speaking to is inequity and equity. Equity is recognizing that there's a response that needs to be deliberately different for one group versus another, for one area versus another. The approach can't be unilateral and the same. And I think that we are still struggling as a society to figure out what it looks like to be okay with disproportionate investment. We still have fairness higher on the list as a priority than equity. And until we start really understanding that equity means that certain groups have gotten a smaller piece of the pie for a long time, and they actually need to get a bigger piece of the pie now in order for them to actually make it to parity. And you're talking about a very specific region within a county. And the state understands that. That part they're getting. What they're not quite there yet is that it's this entire region needs a disproportionate investment in comparison to the rest of the state. And that's a very difficult sell for people who are understanding the inequities and things that are going on in their individual communities in other parts of the state that are not Central California. So what I would encourage you to do, which I'm sure you're doing, is invite as many people as possible to come in person and experience what it's like, because that truly makes a difference. It's one thing to read statistics. It's another thing to invite people to really interact and see people's faces and hear their stories.
I would just say that, if everybody in this room got a pair of shoes, it would be an exercise of equality. If everybody got a pair of shoes that fit, it would be in the service of equity. And I would agree entirely with all of your comments. I think that we're woefully failing on a number of fronts, right? And I think that one of the things that we do need to sort of get is the importance of worst first, right? That we have to address where we have the greatest shortcomings, the greatest failures, and shore them up in whatever way possible. I do think it means starting earlier, right? A number of our schools have Doctors Academy and MIRA programs that are helping to change the trajectory, right? The inexperience of what it is like to even explore healthcare as a career, right? And providing all of the supportive factors to help our students be successful. And you're right, not all of them will graduate ready to enter a pipeline, but it doesn't mean that we can't have more pipelines available in whatever way we can begin to create building blocks of experience that help push them up to new levels. So we have to start from somewhere.
And that's all the time we have. So really, really appreciate Genoveva, Sarah, and Kimberly for the insights. I'm sure a lot of it will stay with you. And so please help me give them a round of applause.